have the outside, but he historically gave it, he has multiple big transfusions.
For anemia.
For anemia. Only past 3 months or before that also? Like, was he getting because of what was the reason for his anemia? They have no outside. Have we evaluated here? Here we have looks like an activation anemia. They consider the possibility of thalassemia also, but then
no, but so many blood transfusions, he had iron deficiency. Yeah, his iron was only 11, and he had so many blood transfusions. We expect the iron to be, and thalassemia also expect the iron to be high. Now then, acute because he had active.
So good evening, presenting Crippled on behalf of Medicine 2. So 26-year-old male, Mr. X from Bangladesh, presented to the OPD with the chief complaints of difficulty in combing hair for 6 months and difficulty in lifting neck up from the bed 6 months and difficulty in climbing stair since 5 months. That is weight loss for 8 to 10 kg over 5 months. History of presenting illness, he was initially absolutely normal for 6 months back. Then he developed a difficulty in combing hair and is using his hand to grasp the object located at a higher level. There is a weakness associated with the pain. There was a history of progressive low limb weakness in the form of difficulty in climbing stair, requiring one person support. He also had difficulty in sitting in the Indian toilet and required one man support to get up from the Indian toilet. There is no history of difficulty in writing and or mixing food. There was no history of buckling of knee. There is no history of losing of footwear while walking. There is no history of joint pain, photosensitivity, dry eye, dry mouth, or Raynaud's phenomenon. The history, the antenatal period was uneventful, is normal vaginal delivery, attained normal, motor, social, and language milestone, normal bowel and bladder habits. So summarizing history, is a 26-year-old male presented with bilateral symmetrical progressive proximal muscle weakness with no sensory and autonomic involvement. So examination wise, the conscious oriented, vitals was stable. No palatal cyanosis clubbing lymphadenopathy, and no calf muscle hypertrophy. There was a periorbital erythema noted over the both eyelids. Malar erythema also present. Other systemic examination, CVS RS also, perrubrum swab, normal. CNS examination, all cranial was intact. On motor system, bulk reduced on the bilateral thigh region. There is an hypotonia on the both lower limb. And power on the shoulder, there is a reduced power on the two on both sides, abduction, flexion and extension. Hip flexion also 2 plus, extension 2 plus, abduction also 2 plus. Deep tendon reflex, there is a diminished deep tendon reflex, bilateral plantar flexor, no fasciculation, sensory system normal, cerebellar signs normal, gait normal, no spine deformity. So summary is pure. Actually, a young gentleman presented with bilateral symmetrical progressive weakness with associated with the muscle pain. The localization could be a neuromuscular junction. In this man, there is no diurnal variation, no fatigability. No, we can think of neuropathy also. There is no sensory involvement. The roots is the root radicular mostly is asymmetrical. There is no radicular pain also. So possibly either a lesion in the anterior horns or muscles. So the localization could be pure motor neuron element type, and the muscle could be a possible localization. And the muscle affected are deltoid and hip flexor, abductor and extensor and the neck flexors. Onset is a chronic, so etiology could be a inflammatory myositis. So differential considered to be dermatomyositis, polymyositis, inclusion body myositis, sarcoidosis, anti-synthetase syndrome, and associated with the overlap like SLE, systemic sclerosis, MCTD, and rheumatoid arthritis and Sjogren's disease. So we have done an investigation. CBC found to be normal. LFT is a mild transaminitis is there, and the CPK is 5,826. And we did an EMG study, shows myopathy process with membrane irritability. And the sentinel myocytic proprietors showed mitochondrial antibody 2 alpha was strong positive, and also MI2 beta was strongly positive. ANA was 2 speckled, and there is no hypocomplementing. DNA or dsDNA also normal, this is 0. And then urine routine shows also normal. So diagnosis is a pure motor syndrome with the bilateral symmetrical progressive element type. with muscle pain. So actually the result, so there is an periorbital erythema also noted in the this thing. You can notice the left side of there is an erythema is there, left side periorbital erythema. So CPK is high with anti-MA2 positivity, EMG shows myopathy features. So diagnose the dermatomyositis. So this is a table from Harrison. Actually, this is a differential for inflammatory myositis. The consider was dermatomyositis. In this, there is an rise in CPK level and associated with anti-MA2 antibodies positivity. And also, we done a muscle biopsy. Actually, report is avoided. So, other than polymyositis, the not involving skin manifestation, and necrotizing polymyositis is associated with the HMG-CoA reductase antibody. So usually seen in among statin users, and also anti-synthetase antibody myositis usually associated with the non-erosive arthritis and fever. And inclusion body myositis usually in this case the CPK is mostly normal. So whenever we found an like dermatomyositis, we should rule out the underlying malignancy. These are the antibodies like anti-transcriptional intermediate factor and anti-nuclear matrix protein associated with the increased risk of cancer. So while anti-MA2 are often associated with the more benign dermatomyositis and a favorable outcome. So my patient also significant weight loss. We evaluated for the underlying malignancy. PET scan was done, was found to be normal, only myopathic changes. So, what is the association between ANA and risk of malignancy in adult onset dermatomyositis? In patient with adult onset dermatomyositis, ANA negativity associated with the increased likelihood of development of malignancy within 3 years of diagnosis of dermatomyositis. So, in this patient, if those who are ANA negative patient, should be close follow. So, treatment is we started on prednisone 1 mg per kg and they followed by methotrexate as a second line visit, mainly on physiotherapy. So learning point is approach to the proximal muscle weakness and the diagnostic approach to the dermatomyositis and the treatment.
Thanks. How is he now? How is he's still admitted?
Oh, he's still there.
So I'm not sure. There's no rheumatologist here. So is the doing a muscle biopsy the norm? I don't think we need to do a muscle biopsy. We don't. I mean, when in the olden days we didn't do a muscle biopsy. We had a high CPK and symmetric proximal muscle weakness more than distal. We just that's correct. That's still the same medicine. So why did we do a muscle biopsy in this patient? Just to confirm the diagnosis. Huh? But the diagnosis is already confirmed. So, inclusion body myositis is rare. We've had 1 or 2 cases, and it's more common in older people. And the CPK elevation is very mild or normal in inclusion body myositis. So, what is the biological plausibility for ANA negative being at increased risk for cancers? I mean, there's no real mistake.
Studies there's like ANA negativity increased risk of
malignancies. Any other questions?
It's actually a very clinical diagnosis, so I would agree with the differentials because neurotrophic rash is a very specific clinical manifestation of dermatomyositis. So given that was positive, does not make sense to include all the other differentials. You can just make a clinical diagnosis.
Was the differentials made for this presentation or in the ward? Made for the presentation. So he's just trying to show off his knowledge. Poor fellow, you're just yeah, but I agree with that. Yeah, I think it's fairly straightforward. This guy is very straightforward because of the rash. Any other questions or comments? So anyway, I think we've come to the end of the meeting. So I think this typhoid hepatitis is something that when we were all in medicine, we thought that hepatitis was uncommon. In fact, I've never seen not a major elevation. So maybe it's a good thing for you guys to do some studies on it. I think. Because I think as far as I remember, it's a rare thing. But you seem to say it's quite common. Yeah, that's strange. That's one thing I've learned from it. But we always thought that I'll go read up also about typhoid hepatitis. Yeah, thanks for that. And I have to give the one best presenter. It's been quite difficult, but I think I'll I'll give it for the clarity of presentation. I'll give it to Dr. Jagachripian. Thanks. Thank you. And for the time, I think the other thing is time. You maintain time. You relieved us of the external presentation. Thanks. But yours, everyone's is good. The clarity was very good. It was very nice. I like the typhoid this thing also. Panic abscess also. Thanks. Thank you.